Okay, so we reviewed these two papers, the social distancing responses to COVID-19 emergency declarations were strongly differentiated by income. So this paper talks about the racial disparity, and the next one, the unequal effects of the COVID-19 pandemic on scientists, that addresses the gender disparity. So let's look at why, so let's go for the racial disparity paper first. So why the low income community suffers the most? So the few reasons that this paper came up with are these four reasons. So first one is the lower income communities already experience worst health outcomes. And the second one is lower capacity to cope with economic and health shocks. Third reason is less access to healthcare. And the fourth one is the pre-existing health conditions. So if we look at the deaths by the race and ethnicity, so this is more recent data. So if we look here, this blue bar actually represents the white population. So this is understandable because there are more white people in US, so they're more likely to die from a disease than the other population. But if we just look at this picture, we will have a wrong idea of what is going on, because when you see this, you'll say that, well, white people are dying the most compared to Black and Latino people. So we have to look at something else. So in this graph, we're looking at the death per 100,000 people. So now if we look here, the highest death per 100,000 people are the Black people. The next one is the indigenous people. And then we have Latino, then we have Pacific Islanders, then we have some unknown races, then we have white, and the last one is the Asian. So this will give us the complete picture of how things are going. So even though the total death is less for Black, but if we compare that with 100,000 people, we have the highest rate for Black population. Do anyone have any idea why Asians have the lowest death per 100,000 people?
Because they have white collar job?
Maybe.
I would say they're the ones that follow the social distancing better than any other. Maybe.
I was thinking more on the lines of it may be possible that people of the South Asian continent might be kind of immune to a bit more set of diseases when compared to this, or would this be something like that?
I think so. We will discuss that. So you're actually right. So we will come back to that. But another reason that I think is COVID-19 actually first started in China. So I think that's why the Asian community were more scared, and that's why they were taking more precautions. That might be the case. And also Black population has the more likely to have pre-existing conditions. So that's another reason why Black is the highest death. Okay, this is data from till September 20. Here we can see that the share of death and share of cases, and also the share of population. So if we look at the first bar, which represents the white population, we can see that 61% is their share of population, 51% is their share of death, and 44% is their share of cases. Now compare that with Black population. Only 12% people in the US is Black, but their share of death is 21%, which is almost 10 times more than their population share. Then we have Hispanic population. So Hispanics are accounted for 17% of the total population, but they're also having the 21% of share of deaths, which is similar to Black population. Okay, now let's look at another graph. So this graph tells us the trend when this death started or the case rise for different races. So the first graph in the top, that represents the Black population. So if the death or cases is more than 100%, so this is like more disproportional. So you can see that at the beginning or during May, the death and the cases were at the peak, and then it went down a little bit, but it still is very disproportionate. So the bottom graph represents the Hispanic population. For Hispanic population, they were actually doing good in the May till August, and then the death actually rise above 100% of their population share. So why this is the case? Do you have any reason, any possible cause?
I would say if you look at like the states that were kind of peaking at that time, they have a disproportionately Latino population, like Florida, Arizona. So it could just have to do with like the timing of when COVID hit different states.
Actually, you're right. So if we look at the distribution of Black population in the US, so if we look at the places where we have the most amount of Black population, these are the states where it hit first. So during the May, it hit New York and this region. So that's why we have highest death among Black population at the beginning. Now let's compare that to the Hispanic population distribution. So it looks like California, Texas, they were hit later, maybe during August or July. At that time, the death and cases actually peaked for Hispanic population. So in other words, whenever the cases or the virus actually hit a state, the minority population actually had the highest amount of death and cases. Okay, now let's look at the Native American cases. So we can see that at the mid-June, the cases actually rise, and the death actually rise on mid-August, or I'd say mid-July. So here's another thing we need to remember, that death is a delayed indicator. So that means the case will rise first and the death will follow. So at the bottom, we have the white population. So they pretty much have stayed below 100%. So their population, so the death share is less than their population share. So now if you look at the distribution of Native American in the US, you can still see that these are the states where the COVID-19 cases actually rise during mid-June. And this is when the Native Americans had the highest deaths and cases. Okay, now we're looking at by state. So this is death and cases
Rafael,
percentage. Yes.
I have a quick question on the previous slide.
Yep.
So what exactly does it mean when you look at deaths beyond 100%? I think I wasn't quite sure of what this statistic meant, the first graph.
So 100% means their population share. So if you think about their population share as 100% was their death share. So it's more than 100% means it is disproportionately affecting them.
So, like, for example, if their total population is 100, does it mean that there are more number of people who have been correspondingly dead who are of Native American origin?
Yes.
But then how does that correspond with other races?
So I think the idea here is that, like, you just take for a state the population distribution. Let's say white 50%, black 30%, and the rest 20%, and then you have this ratio. So the most evenly distributed case would be among the death. The distribution is also 50, 30, 20. But if you are having like disproportional ones, like for example, though like white consists of 50% of the population, but only 10% of the death, then they are below their even share.
Okay, so it's a ratio kind of a thing, not just okay.
Yeah. So it's like 3 people of the same color versus the 2 people of the other color. Then it is affected like, you know, let's say 4 versus 2, and then if it's 4 versus 2, then the most evenly distributed death would be 2 versus 1. But if you are having 1 versus 2, then, you know, that's disproportional. The smaller group is having higher proportion in the deaths, though like the original population size is smaller, so it's above 100%.
Okay. Now, just exactly following in the same lines as your numbers. So with respect to 4 and 2, is it possible then for me to have the number of death cases beyond 2 in the second category?
No, like 4 and 2 means like 2 groups. So yeah, 4 and 2 means 2 groups. So the ratio is 2 to 1. So the most evenly distributed deaths would also be 2 to 1.
Right, I understood, which basically means 50% for each.
And yes, but if each group is not sharing, the larger group is not sharing 2, and the smaller group is not sharing 1, then it's disproportional.
Okay. Makes sense. Yeah. Sorry about that. Yeah, thanks.
No, thank you for asking the question. I was wondering the same thing myself.
Yeah, I think it is more easy to understand from this graph. So if we look at the population percentage, so 61% of white means in total in the US, there are 60% of white people.
Right. And here, if you look at the Native American share, it is all whatever, around 1%.
Right.
So when it said above 100%, I wasn't quite clear on what it was, but I think Boyu sort of explained it to me. Yeah.
Thank you, Boyu. Okay, now let's look at the state-wise death and case ratio. So the yellow, orange, and red represents more than 100% of the population share. The other color represents less of the population share. So these graphs show the death and cases for African American population. So if we look at here, the deaths are less pronounced in the West, but it is more pronounced on the East, which also shows that whenever we have a dense population of African American people, they're more likely to get COVID-19 and die from COVID-19.
Interesting that New York State has insufficient data. I find that interesting.
Yeah. So this is for the Hispanic and Latino population. So interestingly, Hispanic and Latino population also had a lot of cases, but if you look at their death share, more deaths are coming from the Western region, but the case share is all over the place. Anyone wants to comment on this, like why this is happening? Or maybe Hispanic population on the West has less likely to get healthcare. If not, then let's move on. So this is a graph for Native Americans. If we look at the deaths, they are mostly coming from Montana, Wyoming, Utah, New Mexico, where they have the highest population density of Native Americans. But if you look at the cases, this is also true for Montana, Wyoming, New Mexico, Utah. On the East Coast, there is not that much of cases. It is also true that they don't have many population of Native Americans in that region. So this is the overall trend of the different races in different states. So this is for per 100,000 people, and we're looking at only death. This is what we have already seen. There is a clear trend. It's upward. And blacks are the most likely to get COVID-19 and also die from COVID-19.
Rafayet, why is that case? Maybe it's a good, oh, that's the slide?
Yes.
Okay, all right.
So we looked at the facts. So now we have to discuss like why that's the case, why Black population are disproportionately dying and getting COVID-19. So these are some quotes that I found from a paper. So the first one is, while there's no evidence that people of color have genetic or other biological factors that make them more likely to be affected by COVID-19, they are more likely to have underlying health conditions, having certain conditions such as type 2 diabetes. I would like to have your opinion on this.
Yeah, when you brought this up a while ago, I wanted to ask, so you hear underlying health conditions, you've been hearing it for months now. What exactly are underlying health conditions? And so here's a good example of it being type 2 diabetes. But like, what are some other examples? Because for type 2 diabetes.
So diabetes also comes with many different other things. For example, heart disease, kidney disease.
And now does type, like, so those would be underlying conditions.
Right. So if we look at the deaths for different underlying health conditions, so diabetes, I believe diabetes is the highest, has the highest death rate among all other underlying health conditions.
Well,
I think they're also more likely to have asthma, which is obviously for COVID not ideal.
So now, which of these factors are under their control, I guess? Like, is asthma a genetic thing? Is type 2 diabetes a genetic thing? Or is it a product of behaving in environments?
I think type 2 diabetes is not a genetic thing. I think that's a type 1 diabetes. And there is a thing called, so in the low income population area, there is a thing called the food desert. And I think when Obama was president, Michelle Obama has a program for reducing those food desert, and she emphasized that why low income population areas don't have grocery stores, and how they can give foods like fresh foods to people with low income population. So now we are seeing the effects of having those food deserts, and those are causing those type 2 diabetes, and now they're dying from this disease because they have type 2 diabetes, obesity, heart disease, and so on.
I do see that, but isn't obesity mostly caused by like taking in a lot more calories than you're burning?
Yes.
I mean, the factor is that, like, to be honest, like most of our behavior can be controlled by the environment. There's a part which you can control through strong will, but environment is a very big factor. And so if you drive through Jefferson Avenue in Rochester for a large space, you will see like the, what they call, I think there's a name for that, like the small daily shops. And most of what they sell are basically type 2 diabetes inducing foods. And so that's a big problem. Like when in your walking distance, you see like lots of foods, like especially soft drinks, fries, burgers, and so on. So you are more likely to eat it. But of course there is a part of education, there is a part of self-control there. But if your environment is largely designed to make the bad choices easier, it's very difficult to make the right choices.
And cheaper, perhaps?
Yeah, it's extremely cheap. I mean, there are several very good documentaries on that, like the obesity problem in the US, like about the calories issue. I mean, it's much more complicated than that. I mean, just the calories. One problem is that it's cheaper. You can say that it's tasty, but the problem is that it burns really quickly. Like you very soon you will have like another hunger spike, and then you will eat the same cheap calorie. I mean, for example, if you see like the big soda bottles, they cost, like, even if you go to Dollar Tree or places like that, it costs like $1.5 or something. You need like $2 for a small water bottle. So there are policies which resulted in this, but the thing is that the bad choices are overwhelmingly easier to make, and the good choices are hard. That's my understanding after going to Jefferson Avenue several times.
I think, Rafayet, I think we have established enough ground to see why there is the ratio of who is suffering, as well as what's the disparity. Is there anything else before we give a break?
Yes, there are two more reasons. So another reason is racial and ethnic minority members might be more likely to live in multi-generational homes, crowded conditions, and densely populated areas such as New York City. This makes a social distancing difficult. So this is obvious. We have seen that crowded apartment buildings in New York City, and most of those apartments were affected by COVID-19. So this was very obvious reason. Another reason is nearly 25% of employed Hispanic and Black or African American work in the service industry. Compared that with 16% of non-Hispanic white workers. So as we are talking about the essential jobs, that is also true for Black and Hispanic population. They are more likely to do those jobs where they have to travel, they have to go to work physically. And that is the case why there is a big disparity.
Right, and they probably don't have a private car, so they're taking public transportation.
Right. So these are the three major reasons. There might be more. We can take a break right now and then come back and do the exercise.
Can I quickly add a point?
Yeah.
Yeah. So I was wondering what's the baseline, like when we talked about that, hey, Black people are being disproportionately affected and white people and Asians are not. Right. So I wondered, okay, perhaps age might be a reason, perhaps within these population demographies, perhaps Blacks have a larger proportion of, say, 65 plus people, which can perhaps explain that, hey, their people are dying more. So I quickly went to census.gov and ran the numbers. Apparently, it's the opposite story that you can see from the numbers. Like for the Black population, 65 years and over, that fraction has 10.998%. For Asians, it's 11.7, right? For American Indian, it's 10.1. So it's sort of in the 10 range. But for white people, that fraction is 17.71. So if anything, white people should have died more simply because they have a higher, like 7% higher fraction of elder people. But clearly that's not the case, right? So white people are dying less. So that sort of like tells the story that, okay, these effects we're seeing here, like healthcare or transportation or something, like these have to be more pronounced than they seem because the prior probability is biased against white people here.
Yes, I think age is not the only thing that we should consider. So the main considered point is the underlying health condition. So if you are a healthy older adult versus you are a unhealthy young person, you're more likely to die as an unhealthy young person.
Yeah, like the point I was trying to raise is that, hey, the prior probability is the opposite of what we're seeing. Yeah, the prior probability is biased against white people, whereas the actual numbers are biased against Black people. Yeah.
Right.
So Raiyan strikes again with his just-in-time data analysis trick.
I was just going to say that.
All right, Rafayet, before we take a break, could you tell us what would you do after you come back from break? So just like in a show, right? So before you go away, let me tell you what's coming.
So first, I'm going to go with the 4 different metrics that the paper actually discussed. And then we have a design challenge where we divide ourselves into 4 groups, and then we come up with a solution for tracking and helping the minority population, how we can do that. But instead of, I mean, we do have some conditions for this design challenge. In the paper, they have used mobile devices, but in our case, we're trying to be more creative. So we are not going to use mobile devices. And then we can discuss some features and pros and cons of each of the. Okay, so let's just review what the paper have discussed. So they have came up with 4 different metrics. So in the first metric, we can see that right after March, there is a spike of in-home activities among people who are in the higher income group than the low income group. We also see that a trend, and we already discussed this, the median distance traveled well stayed the same for low income population, but if we compare that with high income population, that actually decreased, which was expected because there was lockdown measures. So this is an interesting graph, device exposure. So that means how many people they have came contact with. So I just want to know your opinion on why there are so many spikes in this graph. Can anyone say anything about that? This is actually very interesting.
What's device exposure?
Device exposure measures with how many other devices you have been exposed to?
Well, I mean, there's the natural march happens and everyone gets put on social distancing. So that one's obvious. The number of devices you're exposed to is going to drastically drop given social distancing. Are you talking about the ones in the beginning being more interesting?
No, I'm talking about why there are spikes like this. So why it is a clear trend. Why there are spikes?
Weekends.
Yes, exactly. So there were 5 weekends. That's why in February we can see 5 spikes. So those spikes actually represent Saturdays.
That is interesting.
Yeah.
Nice one.
So the problem with this data is this is from January 1 to April 21 first. And the second is not every state has the same lockdown date. So they came up with a different way of visualizing the same metrics. So at 0 on the x-axis, that's when the event occurred. That means that's when there was a mandatory lockdown started. So we're looking at 20 days before and 20 days after the lockdown. And we're also looking at different income groups. So if we look at the completely at home metric, the yellow line actually increased, which means the high income population were more likely to stay at home. Compare that with the violet one, which represents the low income population. They kept their trend, I would say. So there was not much an effect of the lockdown among low income population. So we all looked at this paper, and now let's look at the design challenge. So next, we will divide into 4 groups, and you have to come up with a design or AI-driven technology to track the movements. So in the previous paper, the paper that we have discussed, they came up with 4 different metrics for tracking their movements. So in this design challenge, you are not allowed to use mobile devices because they already did that. So you can use smart speakers, video-based surveillances, or electronic footprint such as credit card transactions or other electronic footprints.
Social network.
Yeah. So you have to come up with the design or the technology that you want to use. Then you have to come up with different features of the technology. So the features of how do you want to detect vulnerable population with your technology, how you want to design an intervention. For example, how can you use the smart speakers to say that, well, you're going out today, but please don't take this route or that route because those routes are more likely to be crowded, something like that. So I want to see more different creative features of your technology. And also, how do you want to measure the success of your intervention or technology? So that's the design challenge. Now we'll divide into groups, but first, well.
We're going to do this in 10 minutes?
15 minutes.
15 minutes, okay.
Are smartwatches and like Fitbits, are they fair game? Or...
Yeah.
Okay.
All right, I think we got everybody. Rafayet, take it away.
Okay, let's hear from group 1.
Wasif, you wanna go?
You can start.
Okay. Okay. So we were pretty much confused as to what should be the ultimate goal of the technology. So we thought, hey, we'd pick some macro scale sensing. For example, the mobile towers, they can, even for feature phones, they can track which users are connected to a certain tower. So if a lot of people are going from one zip code to another, the mobile phone towers will know that. You can sort of have a macro level sensing from social media text mining as well. people give check-ins, people share their locations, and also talk about what they might be doing this weekend, share photos of like visiting national park or something. So these features can be mined to get a large scale or macro level understanding of how many people are there, say in a national park in a weekend, or in a bar or restaurant, etc. So perhaps once you have that sort of macro level information, the outcome measures we're looking for is to reduce that, right? Perhaps for mobile towers, once the tower knows that, hey, a lot of people have been moving around that particular zip code, putting that zip code into a risk, perhaps it can send text messages, right? That's low tech, and it can just simply send text messages. And that also covers, racially vulnerable people, because they just might not have access to the high-end smartphones. So everyone can get a text message and they'll know, okay, that particular zip code is a no-no place for now. And to assess the outcomes, perhaps we can just take two very similar zip codes, right, with similar social vulnerability index, similar trajectory of infections and deaths, right? In one, perhaps the mobile tower does nothing, and in another, perhaps the mobile tower tries to intervene. And then from the beginning date of the intervention, you can assess whether the treatment zone has any difference in reducing, say, the number of cases, deaths, the gathering size, gathering frequency, etc. So that might be one way to measure it. Wasif, do you want to elaborate on the Doppler-based sensors?
Yeah, so I was also thinking that something that like if we don't use mobile completely, then like the sensor, like the sound-based sensors, they can actually detect, I believe, to a good extent how many people are there. So they pass like sound waves, and from that they can detect how many people are moving, what speed they're moving. So they can be a good way to collect a large scale data from a lot of people without revealing their behavior, something like aggregated level of data. So that's something I was thinking.
Yeah, that's the good thing about Doppler-based sensors is that it does not capture the videos of your faces, yes, right? So there's no risk of identity revelation there, and still you get a macro level understanding of gathering. So yeah.
So Rafa, you had group 2 critique this idea, or?
Let's hear from group 2 first, then they can do both ways. So let's hear from group 2.
And you have 2 minutes or less.
Okay, so I guess I'll just talk about the constraints of the problem, and then one of the others can take over for it. But so we are under the impression that we can't use mobile phone data. We can't use mobile phones. Phones are out of the limit. We're also the impression that the main thing to do is to try to design an intelligent system to solve the racial inequality problem for disproportionate deaths for low-income Black population. So that is the scope of the problem that we try to solve. Okay, Boyu or James?
Yeah, so one of the ideas that we came up with was a Fitbit-like device that you could use to log into places as you go to them. And it would be able to keep track with a small app on the Fitbit-like device. It would keep track of your steps, and it would keep track of your movements between different locations. So when you get on bus, you log into that place. But when you go to a hospital, supposedly with COVID, you also check into the hospital, and based on where you go, we're able to see, when you got on a bus, where you got on, when you got off, and see that people who went to certain places ended up in the hospital, and people who didn't.
Yeah, because we came up with this general idea just considering the cases of the medical center, URMC, because there is a large population relying on large amounts of essential workers there, and they belong to a certain racial group. And we think, this thing might not be the most generalized. It's not like we are gonna deploy it everywhere, but locally or regionally, also given this kind of essential workers work environment, this medical center, it has a pretty strong public transportation network. and lots of people rely on it, we think that it could be a pretty cool local deployment with like shuttle cars, bus station cars, and yeah, that's how we came up with this idea.
Great, thank you. That's all the time we have for group 2. It's 2 minutes, 30 seconds.
Okay, group 2, do you want to say anything about group 1's idea?
I did like the, oh, sorry. But,
yeah, go ahead.
I like the mobile tower idea. I thought it was a pretty cool idea to notify people as they enter those hazardous zip code areas.
Yeah, group 1, do you have anything to say about group 2's idea?
I was not really clear what you're going to do with the Fitbit. So everyone has a Fitbit, they punch their cards, and so the location is known, but how does it help the COVID-19, or what's the intervention?
The intervention is because we have these cards, we know where everyone's traveling. We also know where the hotspots of the COVID outbreaks are. Because there's IDs to the card, we know the roots of the person, and maybe they wake up in the morning and they get a notification, and it's maybe a color, and the color means to try to check a different way to work.
Fair enough. Yeah, that makes sense.
Good.
One
Group
question
3, yes, go ahead.
I was thinking about Fitbits, right? So many individuals who may come from lower socioeconomic status who need this technology may not have Fitbits.
Yes, and adding me to the
We need to
Fitbit.
give them all Fitbits. That was the first one. We had to give them the Fitbits.
Okay, all right.
Adding me to the list will be helpful as well. The giving.
No, I think they explained it, right? That, hey, they're narrowing down their scope for people, essential people, say just for the URMC, and then give it to them. So that makes a lot of sense. Narrow down your scope like that.
Great. Group 3. 2 minutes, go ahead.
Okay, so essentially the idea we had was for a Arduino Nano based chip, which you would basically attach to your shoe and just forget about it. Essentially that's the idea. And what the chip is basically doing is that it's exchanging anonymized tokens with all other chips it's coming in contact with. So you and it's so you're getting an idea of how many people you're coming, like how dense of an area you're going into. And it's also tracking how much physical activity you're getting. I think Erin and Vishesh can go into the features and the outcomes.
Sure. So for the features, I think we thought mainly one of the, as we talked about in the contact tracing discussion, I think that people are sort of resistant to sending their information out. So this would be just kind of a one-way data transmission. We're on the chip. Based on where you are, you'd be kind of feeding in information that could calculate sort of your risk. So based on where you live and the prevalence of the disease in that location, the number of people you come in contact with, whether it's indoors, outdoors, you get kind of a risk score, and then you just get a flash of light, whether you're in the green, yellow, or red. So kind of keeping privacy concerns at bay.
Yeah, and just in terms of outcome measures, what we were basically assuming is 2 basic things. Firstly, we need to make sure that one of the measures that we have is that it gives the right information to us that reflects the correct behavior on the ground. So basically, we need to make sure that whatever information it is feeding us is something that is corresponding with whatever the people are doing physically on the ground. And secondly, if we actually manage to change the behavior patterns of people based on the information that we receive and based on various recommendations that we can potentially provide, that is also something that's going to be definitely useful, for all of us. So those are 2 of the sort of top outcome measures that we were thinking of.
And just a concluding point, Arduino Nanos are very cheap, and even with accessories, it should cost like $10 to manufacture one unit.
Great idea. Let's hear from group 4.
Yes, so our main idea is to make use of those public cameras like CCTV in those crowded places, and this may sound not very feasible right now. We are wondering if it's possible to visually identify some health problems, because since we think the underlying issue with some inequality problem with different races is because it's still because of the health conditions, like pre-health conditions that they have. So we're wondering if we can just warn people who might have such health problems like obesity, or they are using some specific medical devices, and identify those features and trying to give some notification to these people to like not go to those crowded places or high-risk places to protect them better. And also we think that facial identification can be helpful to identify people who frequently visit high-risk places, and use such information to protect certain group of people. And yeah, that's our main idea. And I'm wondering if Melissa and Jeannie wants to add something.
Yeah, actually, one I just thought of now, we could maybe look at subway stations, or when people tap into certain gates, or even I think like some public buses have them as well. And so if one gets super overloaded, you can either suggest other routes or close it down completely if necessary.
Do you have anything about Group 3's idea?
Yeah, I think it's. I think the good thing about it is definitely like the onus isn't on an individual person to keep up with anything. It's just like tied to their shoe. They forget about it, like you said. I guess maybe it sounds a bit like dystopian and the government tracking you, and that could maybe be because I don't know how people would be a fan of it.
Okay, Group 3, anything you want to share about Group 4's idea?
I guess I had the same concern about like privacy with like facial identification, and like telling those people to be safe, and like just seeing how like who's more at risk. But I guess like in both ideas, there are ways to make these systems privacy preserving. Yeah, that's all I have to say.
I think one quick point that I sort of wanted to check was, so I think with the advent of masks and everything, I think facial recognition is going to be even more difficult. So I think in public transportation systems, because even my own iPhone, just struggles to recognize me. So I'm not sure as to how effective facial recognition systems would be in public places, but that's just something on top of my mind.
Okay, great discussion. So let's move on to our next topic, which is the gender disparity.
Rafayet, before you start, can you tell us how long you're going to speak and what are you going to do? When are you going to, I'm asking when am I going to get done?
I think I'm going to do speaking for about 10 minutes. Then we have another exercise. That's going to be short.
Okay, so hopefully before 7.
Yeah, hopefully.
Okay, great.
Okay. So here we're looking at a graph that's telling us about how disproportionately female dominated jobs were impacted due to COVID-19. So in the y-axis, we have female share of employment, and on the x-axis, we have the share of jobs impacted between the 2019 and 2020. So you can see that the larger the circles, those are the size of the jobs, and the darker colors, the gray and black, represents female dominated jobs that were more affected and less affected, versus the male one, the blue one. So in general, it is a clear trend that the jobs that are dominated by women, they have, these circles are larger for those jobs, which also represents why females are more affected, not only in research, but in other jobs as well. Now, what can we do? What's the impact in GDP? So here are three different graphs that we can see. So on the left, this is the case where we do nothing. So we do nothing, and what should be the GDP? So the GDP will go down by 1 trillion by next year, or sorry, 2030, if we do nothing about COVID-19. So on the middle, we have, if we wait to take action, so we will discuss what kind of actions we can take to remove gender disparity. So if we do that, or if we do a late action, then we are expected to have an $8 trillion of GDP more than 2020 by 2030. But here's the good case where if we take the action right now, then we have $13 trillion more GDP by 2030. And also if we look at the parity of the gender, that will increase for women. So it's now 0.61, it will be 0.71, so 10% increase.
What action are we talking about here?
So that's the thing that we want to discuss. So we haven't thought about what kind of action. So there are different actions, for example, policy changes, helping women with childcare and so on. So we can do those. So the key point is when we want to take those actions. Is it now or do nothing or late action? So this graph represents different countries. So this is not exhaustive graph. We only have 5 different countries here. So 6 different countries here and the total world population. So the blue and gray one represents do nothing scenario, and the blue bar on the right represents the take action now scenarios. So if we look at the bottom, it actually represents the GDP, how it will grow. And we also can take a look at the share, percent share between male and female. So you can see that in France, in most cases, if we take actions now, then we'll have more participation from female if compared that to do nothing scenario. So now if we look at our paper that we have discussed, so this paper actually focuses on researchers only. So we can see that the time they spend per week, that was actually decreased for almost everyone, including male and female both. Surprisingly, the research actually affected most for multiple different cases, as you have already discussed. I'm not going to go over on that. And if we look at this graph, this also looks at, the first one looks at in which area that were most affected. All of those areas were actually affected, but those bench researchers who actually need to go to the lab and perform the research, they were affected the most. For example, chemistry, biochemistry, or cellular molecular biology. So on the right side, the rightmost graph, this is the most interesting one, because this is a this graph represents after applying the lasso coefficient. So what is lasso? Lasso actually penalize those features where the effect is less. So it will basically remove features from any sort of like regression analysis. So now if we look at these features, so you can see that the female who has 0 to 5 years old dependent, they were most affected. And also the researchers who actually work on biochemistry or cellular molecular biology, they were the most affected one. And now if we compare that with health sciences, they were not actually affected. They were actually benefited from COVID-19. Also economics, mathematics, and statistics. So this shows that actually the computer scientists that we're actually getting more benefited from staying at home and do more work.